Hello, everybody. My name is Emani. I'm a cardiac surgeon at Boston Children's Hospital and MGB Brigham campus, and I'm here today with Dr. Emile Bacha, who is a professor of surgery at Columbia University and chief of cardiac, thoracic, and vascular surgery at Columbia University and New York Presbyterian Hospital, co-director of the Children's Heart Center at New York Presbyterian. Dr. Bacha is also the current president of the American Association for Thoracic Surgery. Thank you, Dr. Bacha, for being here today.
Thank you.
Some really exciting news with the recent publishing of the ACHD guidelines on ACHD, and we're here to talk a little bit about some of the findings and recommendations, particularly as it pertains to some of our patients. It was a big document, a lot to cover, obviously, but I was wondering if just as an overview, you can sort of speak to what you thought was exciting new that came out of the guidelines.
Yeah, thank you, Ram, for having me. Appreciate it. I appreciate our friendship over decades now, and having you as a colleague. I think this document was very well done, very well written, and is also very, very timely. ACHD as a field is a young field that's moving very fast. And as such, I think guidelines like those have to be updated regularly to reflect the current thinking. In addition to this, by default, there aren't enough ACHD specialists in the country or in the world. And so by default, there's going to be some adult cardiologists practicing ACHD, and guidelines are also very good for them. So I think this was a very well done job, and will be very beneficial.
Yeah, speaking a little bit more about that, there were some new recommendations regarding teams and team composition in taking care of patients with ACHD, and specifically, I think for both non-cardiac surgical procedures as well as for invasive cardiac procedures, both surgical and interventional, there was a recommendation for having an ACHD cardiologist involved. But I noticed that there wasn't much there on what the cardiac surgeon sort of requirements should be. And I was wondering if you could just comment on that. You talked a little bit about it in your commentary. What are your feelings on team composition and who should be ACHD trained? How does that look?
Yeah, thank you. Well, I think that ACHD is the ultimate team sport. You cannot practice ACHD without having all the components of the team there, especially in the large academic medical centers that have large ACHD populations, because they've been doing pediatric cardiac surgery for a long time and therefore have a lot of survivors. And also the recognition, I think, in the general population, but also doctors in general, that these patients deserve to be seen by a specialist. But again, it has to be a team sport. The surgeon, after all, congenital heart disease is often a mechanical problem, holes and narrowings and things that you need mechanical tools to fix. So replacing valves, opening up stenoses, closing holes, these are the kinds of things we do. And you need a surgeon mostly. Of course, you can do that in the cath lab sometimes, but mostly you need a surgeon. And so the surgeon has to be a key component of the team. And the heart team concept that was popularized in the TAVR world is absolutely correct here as well. I mean, what we do at Columbia, I'm sure, and I know you do the same thing, is we have a weekly conference to discuss patients, which is a multidisciplinary conference. And also, whenever I get sent patients by outside cardiologists, I get them seen first by our own ACHD cardiologist. This is not a sort of redundancy. It's really something that's important, that they get seen first by a medical specialist specialized in this, and then I'll operate on them if that's the case.
Yeah, you also mentioned in your commentary about the shortage of ACHD specialists, specifically ACHD cardiologists, in this situation, because if we're making a recommendation now that everybody needs to be seen by an ACHD cardiologist, do we have enough ACHD cardiologists, and how do we deal with that person power issue?
How do we deal with the shortage, and do we have enough ACHD specialists? We don't have enough ACHD specialists. As the oft-cited statistic that there are now more adult patients living with congenital heart disease versus children is true, and we definitely do not have enough specialists. So I do think that this is something that the societies have to deal with, the medical societies, ACC, AHA, that the training to become an ACHD specialist, boarded specialist, is really, really long. And so as such, I do think they need to look at ways to shorten that training by a year or two, because otherwise it's a daunting task to be looking at 8-9 years of training. That's the first thing. The other aspect is on the surgical side, and who gets to do ACHD surgery. I think that's also a very important piece. We have seen some studies, published statistics of results being better when congenitally trained cardiac surgeons do these kinds of surgeries. I do believe that is correct. That is also my observation in real life. Now, we're not talking about simple secundum ASDs here, but we're talking about the more complex work that needs to be done. You do need congenital training to do this kind of work in adults, and you need adult training. So you cannot, it's hard. You have to have both. You have to have the congenital/pediatric training under your belt, and you have to have a standard adult fellowship also done in order to be a competent and safe ACHD surgeon.
Well, there's certainly a lot there to continue to discuss, but I want to move on. The document covers a lot of lesion-specific recommendations that I think are interesting and new, and specifically around management of Fontan circulation and single ventricle palliation. Lots happened since the last ACHD recommendations. Do you want to comment a little bit on how you see the guidelines shifting the way we care for adult Fontan patients?
I'm happy to comment on how the guidelines deal with the, indication for management of adult Fontan, but also, if you don't mind, even as a more general standard. What I really was happy to see was recommending earlier surgery in general. Of course, we have to be careful about early surgery. We don't want to operate on everybody, and we want to have good, solid indications to be able to help people. But by and large, my observation over now, 25 plus years in the field has been that very often patients were sent too late to the surgeon. And it's been for the last 25, 30 years a sort of a tug of war a little bit to say, please send patients earlier to surgery. If you know a patient requires surgery, let's not wait until the patient is 45 years old to send that patient to surgery. Don't wait until the heart is, sort of at its end game, and try to send the patient earlier. So that's the first statement. With the Fontans, adult Fontans, it's much of the same, and it's the difficulty in the Fontan population, adult Fontan population, is when do you send a patient for further surgery? And of course, the big looming thing is a heart transplant. And then furthermore, when do you do a heart liver transplant? Because that is the thing that has become in some ways democratized more over the last few years. I mean, I remember 15 years ago when this heart liver movement started, it was really, those operations were very, very bloody, very tough to do. The results were not good. And it's a testament, I think, to the surgical community, both cardiac surgery and liver surgeons, that they've come together. And I mean, I know for many institutions, including ours, it is now really, we don't think it's become a procedure that you do as a matter of fact. We have our own routine, how we do it. We're not, of course, there are big surgeries, big, heavy surgeries with morbidity, with mortality, but by and large, it has been conquered, and we know how to do these operations now. So that has become less of a factor. So when do you pull the trigger? When do you put a patient down the list of heart transplant, heart liver transplant, or even I want to mention upsizing the Fontan conduit? I think we are recognizing now that Fontan conduits, whether they're done as extracardiac Fontans, most often the extracardiac Fontans will do this, or lateral tunnel. The conduits are too small for adult patients, and I think it's an under-recognized problem that we have to seriously look at and consider doing something about.
Yeah, it was also good to see recommendations on evaluation of the Fontan patient, because I think it all starts with an evaluation, whether it be with a liver specialist, with a cardiac catheterization. Those studies are important to kind of help us start to think about interventions and following these patients. So that was very nice. And speaking to the timing, you talk a little bit about early surgery, particularly for patients with Epstein anomaly, and some of the changes in the surgical techniques over time. I was wondering if you could just expand upon that.
The question about when to send a patient to surgery, a patient with Epstein's disease, it's an important question, especially in the asymptomatic or so-called asymptomatic patients. Of course, the job of an ACHD cardiologist is to uncover symptoms. You know, I think if you're asymptomatic, sitting on the couch all day long, and you're 25 years old, that's not quite asymptomatic. Are you able to walk 2-3 blocks? A 25-year-old, you should be able to do more than just sit on the couch. So I think asymptomatic has to be defined exactly what it is. That's one piece. And what kind of workup do you do to uncover symptoms or ongoing damage to the heart is another piece. But also the other component of this is how safe is the treatment that you're offering the patient. So and how effective is it? How safe? How effective? The safety, I think, of Epstein surgery is pretty clear. I mean, that's for decades, even before the cone procedure, it was a safe surgery in the sense that we weren't harming the patients necessarily. Degree of the rates of heart block were fairly low. I'm talking in the hands of an experienced, knowledgeable surgeon. But now, since the development of the cone procedure and the modifications with adding patches, and most importantly for adult, adding annuloplasty devices, rings, to the procedure, which is now routine in adult cone procedure. I think we can now offer a procedure that is reliably effective in terms of decreasing the degree of tricuspid regurgitation and hopefully improving RV function over the long term, and decreasing the burden of arrhythmias and increasing quality of life, and hopefully, ideally, that nobody's proven that, adding to a lifespan of a patient with Epstein's.
I was also interested to see a new section on vascular rings in this recommendation. I was wondering what your thoughts were on sort of the management of vascular rings in ACHD patients, and how the recommendations dealt with that.
Yes, thank you for the question on vascular rings. It's actually an important. It's a rare finding, but it's actually an important one. And so vascular rings are, you can think of them as benign lesions. All quote unquote, all you have to do is divide the ring and you're done. But we know, and your group is leading the way. We know that they actually can cause much more trouble than expected. But the adult patient with the vascular ring, especially the one that has been undiagnosed and now comes with a large diverticulum of Coumarel, with a significant compression of the esophagus, of the trachea, and complex sort of aortic arch problem. That is a patient that is actually very complex. And often these patients have overlying psychiatric problems just because they've been having these symptoms of not eating well and not breathing well, or both. And so they are, but nobody has diagnosed them. So they've been living for decades with this issue. And now there's a diagnosis, and now what to do about that. And this is an interface, in my opinion, of congenital heart surgery, aortic surgery, and maybe even vascular surgery. And these kinds of patients, obviously the workup includes, extensive, CT angios and angiograms and things like that. But they are not patients that I like to tackle myself alone, because I don't have the expertise as a pediatric cardiac surgeon and an adult congenital heart surgeon who does not deal with adult arches on, I'm not talking ascending aorta, but I'm talking transverse arch, distal arch, descending aorta. A lot of that work has migrated into the percutaneous world. Sometimes a lot of it has gone into the hybrid world. Do you do a left thoracotomy to approach this? Do you do a sternotomy? Do you work with a vascular surgeon? Do you have an interventional cardiologist? So and every patient is unique. And so those are complicated patients. I remember sort of my own experiences early on in that particular field, granted very few patients, but where I had a young man show up like that, and we were just, sort of struggling to manage the problems and just not equipped enough as a single person to deal with it. So you have to have multidisciplinary on the surgery side to deal with them in a correct way.
Yeah, I really liked your comment that there should be really a close interaction between, especially on management of aortas, between our adult colleagues who have really advanced techniques in management of the aorta, along with the congenital heart surgeon who sort of knows what the anatomy was like. And I think that is that's sort of an area that we can continue to develop. I was wondering if I could ask somewhat of a provocative question is, what do you wish the guidelines had addressed, and perhaps will be something for the next version of the guideline?
That's a great question. What was sort of left out of those guidelines, which again are very, very comprehensive? I think that there may be a blind spot of ACHD, but practitioners, and I mean that not at all in a negative way, is that the pediatric cardiac surgery and pediatric cardiology moves on with new procedures and new ways of managing patients. And those patients are now, for those who practice pediatric cardiac surgery, we see, Nikaido of aortic translocation, double root translocation, biventricular repairs that you're the champion of. So small, patients in small left side. We see patients who are getting Epstein's repairs after having had a Starnes procedure. So those are patients that we don't really have adults or even HLHS patients that have survived in decent shape now that we can do the Norwood procedure, the stage palliation in sort of a, I would say, in a better, giving them better quality of life. So you and I have patients who are born with HLHS I have patients who are athletes, athletes in their own way, but they are athletes in their early 20s, and they've had a Norwood and a palliative procedure. So these patients are now hitting ACHD world. And those, what do you do? Aortic translocation. What do you do with problems with the neo-aortic valve, or even more difficult problem with the biventricular repairs that were done on the edge of what's possible? How do you deal? Do they have pulmonary hypertension? Do they have? Do you have to reoperate on them for certain? Do you have to reverse and use the RV, reverse by V of an initial by V repair? If the RV is good, and even all the reverse 1.5 patients that we have now, all of these patients are new cohorts. And I would end by saying it makes the field exciting. At the same time, it makes it so that you kind of keep thinking anew about new problems. And so it's really, I find ACHD cardiologists very smart people who like to deal with problems, and this is the next wave of patients that's coming to them.
Well, it certainly seems like in order to be able to practice and with full knowledge, you have to be able to be up to date on what happens in the acquired disease front, but also what's happening on the pediatric front. And I think that's a lot of information. We don't always have shared venues and fora for discussing these kinds of topics, but I think it makes sense to really smoothen that transition. Thank you very much, Dr. Bacha, and I hope everybody enjoyed this interview session.
Thank you. Thanks for having me. It was a pleasure.